Welcome to the all viewers and well-wishers of the world. The purpose of my lecture is learn the knowledge from the world and return the knowledge to the world. Motto of my life is learn, earn and return, as I have learned a lot, earned a lot. Now it's the time to return a lot to the world. The topic of today is Amebiasis. Amebiasis, the other names of this disease are amoebic dysentery or Amebiasis. It is an infection of the intestine caused by the parasite amoeba, which is Amoeba histolytica. Symptoms present with no symptom, mild or severe symptoms like bloody diarrhea with abdominal pain. Complications are intestinal like severe colitis, chronic perforation and anemia. Extraintestinal complications are like the liver abscess, lung abscess, brain abscess, kidney and cutaneous involvement as an extra complication. So here one can see the amebiasis patient with pain in abdomen, and then the patient may be having the vomiting and the diarrhea. So these are usually presentation of amebiasis. Amebiasis, diagnostic method for that is stool examination or antibodies in the blood, X-rays and ultrasonography just to localize any abscess besides intestinal involvement. Differential diagnosis is bacterial colitis, and there is prevention is by improved sanitation, and treatment is tissue disease, metronidazole, which kill the parasite in the tissues, then tinidazole, nitazoxanide, dihydroamidine, and chloroquine, which are usually used. Intestinal infection need diloxanide, furoate, and idoquinoline. For extraintestinal infection, sometimes the surgery is required if the abscess is producing the pressure symptom. Now the history of the disease is amebiasis was first described by Fedor A. Losch in 1875 in Russia. In 1891, terms amoebic dysentery and amoebic liver abscess were used in the medicine. In Philippines, 1913, it was found that upon swallowing the cyst of Amoeba histolytica by the volunteers can develop the disease, and that has developed the disease at that time. In 1933, there was Chicago World's Fair outbreak by the contaminated drinking water contaminated with Amoeba histolytica. First formally recognized by the WHO in 1997 that Amoeba histolytica was two species responsible for this disease. In 1998, there was an outbreak of amebiasis in the Republic of Georgia. Now, epidemiology. Amebiasis is present all over the world, so it is a cosmopolitic in origin. Worldwide incidence is from 0 to 50%, and it affects about 50 million people, mostly in the tropics and subtropical areas, because these are underdeveloped countries, and it is very less in the developed countries because of the good water and sanitation management. It is more in the rural area than in the urban area. Majority is with the non-invasive Amoeba dispar. Amebiasis is the third most common cause of death from parasitic disease, and it is next to schistosomiasis and malaria. Areas of the high prevalence are Indian subcontinent, southern and the western Africa, Far East, South America and Central America. Molecular epidemiology tells that about 25% seropositive for the Amoeba histolytica in the endemic area. Now, about the habitat of this parasite, man is the principal host for the trophozoite and the cyst, and it has been found also in dogs, cats, and rodents. They are also infected by this parasite. It occurs as trophozoite, or that is the vegetative form. It resides in the mucosa and the submucosa of the large intestine of the man. It is also present in the abscess of the liver or amoebic abscess in the lung or the brain. These contain trophozoites. The trophozoites are capable to divide and multiply. The other form, the parasite, is the cyst form that is found in the large intestine, and it is excreted in the feces, but they are never present in any abscess like liver abscess or brain abscess, because these cannot divide and multiply. So here one can see the Amoeba histolytica, the trophozoite. It have got a nucleus and chromatin, then karyosome, then pseudopodia. These are the false foot by which it is mobile and move. That is said to be the legs of the amoeba. And then it have got the food vacuole and cytoplasm, and in the food vacuole it has ingested the red blood cells, so looking red because of containing the red blood cell. So here is the cyst form, and there is one chromatid body which is diagnostic about the cyst, and then karyosome. So one can recognize by these features that it is the cyst of amoeba. Now, transmission of the disease, that is it means the entry of the cyst into the human body, so that is called transmission. Trophozoites outside the body are not infective, and the transmission is number one, fecal oral route via the carriers. They are the source of the infection, and they pass cyst in the feces, though they do not develop the disease, but the carriers are able to pass the cyst in the feces, and they spread the infection by contaminating water and food, which they do handle. Number two, transmission is contact, that is indirectly with the dirty hand or the objects, and by the anal oral contact. So that is, cyst in the fingers can survive for 15 minutes, but if these are swallowed, they do produce infection. Latent infection or the hidden infection can become invasive in a setting of impaired host immunity, so they become opportunistic. Third is insects, houseflies, cockroaches. They take the cyst on themselves, on their body, and then they deposit on the food on which they sit. And continuing the transmission, number four is food and water. When food preparation is not sanitary or up to the standard, or when the drinking water is contaminated, so it is endemic in the regions of the poor sanitation system. Number five, transmission is anal transmission, or it is also called sexual transmission, that is seen among the male homosexuals, those who are having exposure to the fecal matter during their sexual contact. Number six is that amoebic dysentery is one form of the traveler's diarrhea besides bacterial or the viral in a region. The travelers do travel in the endemic area, and they do have by chance the cyst. swallowed by contaminated food. Now, number 7 transmission is there is no animal reservoir, so there is no spread via the animal. So here one can see stool from the infected person, that is carrier, by the hands, by the contaminated water, by the contaminated food, and by the hands as well. Human becomes infected from the water, food, or the hands, as this carrier is going to transfer the cyst to these areas, and that is going to infect. The woman is a beautiful melody when the man is a good musician. So melody can only be good when the musician who is handling is good. Now, coming to the life cycle of the disease, amoebas multiply in the host by the binary fission, that is 1 divided into 2. Cysts and the vegetative form pass into the feces. Vegetative form die outside the body if swallowed, and die in the stomach acidity also, so not produce disease, and it is the cyst capable of disease. Sometimes these trophozoites are seen in the loose motions, acute dysentery, and cysts are mostly the infected to the man. Under unfavorable conditions, trophozoites changes to the cyst, and in the favorable conditions, cyst changes to the trophozoites upon getting the favorable condition. Cyst can live in the fresh water for 2 days at 4 to 8 degrees centigrade, or in ice water for 1 to 2 weeks. Cysts are killed at temperature 40 degrees centigrade, and these are resistant to the many disinfectants. So here one can see the typical fecal oral life cycle, that is the trophozoites which are just going to having the feeding, they are motile and they are capable of replication. But when the conditions are not favorable for them, they just go to the encystment and changes to the cyst formation. And these cysts are passed in feces, and these are resistant to many disinfectants, but these are very effective to the man. So when these cysts are taken up by the man, there is a procedure called excistation, mean cyst burst and release the trophozoite, which is capable of feeding and replication. So they divide to multiply into many trophozoites. Now, here one can see the trophozoite, that is the endosome, that is the pseudopod, I have told you, the legs of the parasite by which it is mobile, and the feeding vacuole filled with the RBC, I have already shown you in the previous diagram. And here is the cyst, and that is the nucleus of the cyst, that is having endosome and that is having condensed chromatin. So that is the point of recognition of the cyst under microscope. Now, coming to the pathogenesis, incubation period is 1 to 4 weeks. That after ingesting the cyst, one can have disease after 1 to 4 weeks. Lesions are intestinal or primary, or the extraintestinal or the secondary. First, we are going to discuss intestinal lesion, which are also called primary lesion. So, the disease can involve only the large intestine, any part of the large intestine. The trophozoites reach the colon and colonize the mucosa of the colon, and proteolytic enzymes in the parasite body that causes lysis of the basement membrane and the proteins of the mucosa. So, Entamoeba histolytica causes the tissue damage by 3 main events, that is direct host cell killing, then inflammation it causes, and the parasite invasion of the mucosa. This digestion make the classical flask-shaped ulcer in the intestine or the colon. So here you do see number one, the trophocyte is invading the lumen. From the lumen it is invading and breaking the basement membrane, and here it is going to reach to the submucosa, and when it is in the submucosa, the peritoneal cavity covering this other layers of the intestine, and that is going to release the neutrophil to combat these amoeba. But sometimes that amoeba is able to penetrate the muscle layers, and when it is going to penetrate the muscle layer, that can enter into the portal vein. So there is metastasis via the portal vein when this amoeba erode the muscular layer of the intestine. Now, continuing the intestinal lesion or the primary lesion, now Entamoeba histolytica secrete LPPG, lectins, cysteine, proteases, and amoebopores. These are the weapon of the Entamoeba histolytica. The lectins help in the attachment of the parasite to the mucosal layer. Amoebopores destroy the ingested bacteria in the colon, and the cysteine proteases lyse the host tissues, and the other molecules like PAT, MK, myosins, G proteins, C2PK, CA, BP3, and EHAK1 helps in the ingestion of the intestinal cells by causing the phagocytosis of these cells and the tissue by the enzymes created by the amoeba. The other lesions are extraintestinal lesion. These are called secondary lesion, and it include when the trophocyte reach to the liver, brain, lungs, and pleura, skin, kidney, and spleen. So the first extraintestinal lesion or the secondary lesion is hepatic abscess. It occurs in 5% of the individuals with the intestinal amebiasis, mostly in the patient without overt intestinal amebiasis. And sometimes the patient do not have intestinal amebiasis, but that can have the liver abscess. That is 1 to 3 months after the dysenteric attack occurs, hepatic amebiasis or amoebic hepatitis can occur. Root of the infection is trophocyte enter the blood via the portal vein. I have shown the diagram. So that leads to the thrombosis and the ischemic necrosis of the liver cell when they reach to the liver. Infiltration of the neutrophils, so the liver abscess occurs. There is local discomfort, malaise, and weight loss is there. Complication of the hepatic amebiasis includes subdiaphragmatic abscess because the liver is lying below the diaphragm, so there is subdiaphragmatic abscess, or it can be the perforation of the diaphragm, so the lesion can go upward to the pericardium and to the pleural cavity to cause the problem. When it is below the diaphragm, so that is subdiaphragmatic, but when crosses upward, it is going to involve the pericardium and pleural cavity. So here the amoebic abscess caused by the Entamoeba histolytica, as one can see the liver structure and the portal vein is just going to make reach of the trophocytes here to cause the liver abscess looking like this. And hepatic abscess that can lead to the perforation to the abdominal cavity, so that is causing the amoebic peritonitis and the perforation of the skin forward that can be causing the ulcer, and that is called Amebiasis cutis. So that was all about hepatic abscess. Number 2 is the cerebral or brain amebiasis. The trophozoite reach the brain through the blood vessels and cause the amoebic brain abscess and amoebic meningoencephalitis, or this amoebic brain abscess can occur as complication of hepatic or the pulmonary abscess also. Number 3 is the lung and the pleural involvement, that is called pulmonary amebiasis. It is rarely primary through the blood. Usually it is secondary as the complication of the hepatic abscess and the direct expansion through the diaphragm. It means that the trophozoite do not reach via the blood to the lungs, but it is indirectly as a complication of hepatic abscess. As I have told you that hepatic abscess is lying just below the diaphragm and the lungs are lying above the diaphragm, so the perforation can lead to the involvement of this lungs and pleural amebiasis. That is the perforation of pleural cavity and lung. So here is the brain abscess. As one can see, the abscess in the brain because of the trophozoite, and also here the abscess the brain through the via the involvement of the trophozoite. Now, the lungs and the pulmonary amebiasis cause the lung abscess, pulmono-pleural fistula, empyema, lung and the broncho-pleural fistula. There could be superadded bacterial infections common, so there is fever, cough, dyspnea, pain and vomiting is there. In pleura involvement, chest pain, dyspnea, and there is excessive sputum. Number 4 is the kidney or genitourinary involvement, that is always primary through the blood, but urogenital tract amebiasis derived from the intestinal lesion. Intestinal lesion, if these are extensive, that can also involve the kidneys. Amoebic vulvovaginitis or the May disease, rectovesical fistula and rectovaginal fistula can occur as a complication when the intestines are involved. So here one can see pleuropulmonary involvement, and that is the metastatic lesion in the other organs of the body, splenic amebiasis and amebiasis of the penis, amoebic pericarditis, rupture of the liver, left lobe abscess, and that is going to cause high fever, epigastric pain, dyspnea and pericardial rub if the pericardium is involved. Now, spleen or the splenic involvement produce abscess and adherent splenic fracture. Then skin or dermal or cutaneous amebiasis, it is not primary but the direct expansion. I have already told you that the intestinal involvement can directly involve the skin, causing the skin problem. Skin around the sites of the colostomy wound, perianal region overlying the visceral lesion, and at site of the drainage of the liver abscess are mostly involved. Intestinal or the hepatic fistula occurs. Urogenital like labia, vagina or penis is involved. So when you are in doubt in the skin ulcer which is not responding to the antibacterial, always consider that it could be the amoebic ulcer because of the Entamoeba histolytica. So here one can see the cutaneous amebiasis, and here also the cutaneous that is involving the forehead and the eye. Here it is involving the penis, and there is the scrotum and the penis that is also involved as part of the cutaneous. Now, there are certain complications which are confined to the intestinal lesion. These are called complication intestinal lesion that involve the colon mostly, but sometimes cecum, appendix and ascending colons involved. There is hemorrhage, perforation and peritonitis, gangrene of the gut and the fistula formation is there. There could be pericolic abscess, amoebic appendicitis, anemia due to the prolonged intestinal bleeding inside the abdomen that is causing the anemia. Then there could be formation of ameboma. It is a granulomatous mass or a nodule seen in the wall of the ascending colon or the rectum due to the immunological cellular response of body. It can be confused with the appendicular mass or the tumor of the colon, and it consists of trophocytes, fibroblasts, granulation tissue, eosinophil plus neutrophils that form the ameboma. So here the story of the life cycle is that if you just see the number one, that is the cyst that is being taken up by the man, and these are swallowed and they reach to the stomach. From the stomach, the cyst just opens here. One can see from the stomach, it goes to the intestine, which is blue in color. So here is the cyst that is excitation, means the cyst that burst and just release the trophocyte here. Now, third process is that cyst changes into the trophocyte, and here one can see the trophocyte reach to the large intestine that is yellow here. So these cysts, number 3, these are going to reach here. Now here the cysts multiply, as you can see. These are going to multiply, and these are when they are going to multiply, these become invasive. As one can see in the intestine, these are non-invasive colonization. But when they reach here at this part, these are going to cause the intestinal disease. So they produce the disease here, and they also come out and become extra intestinal disease, and they can reach to the lungs, and they can reach to the blood, and via the portal vein they enter the blood. From the blood they can reach to the liver, they can reach to the lung, and they can reach to the brain. And those cysts which are having invasive nature, these are going to have these diseases. But some of these trophocytes, when they reach at number 4, at this part of the colon, they just transform into the cyst. As you can see, the cyst immature and mature, and these become more mature here, and then they exit from here in the feces to become the mature cyst. And these mature cysts just are going to be taken by the man, ingested, and repeating all this cycle. So that is extra-intestinal amebiasis. One can see hepatic, cerebral, pulmonary, genitourinary, splenic, and cutaneous. As one can see that when these are here, it can reach through the blood to the lungs, to the liver, and to the brain, and also forward to the skin and to the spleen